Well, good morning, everybody. Thanks for the kind introduction, Dan, and thanks for your attention. Welcome to California and Napa, and my new home, essentially. And thank you for the honor of membership in an organization I've long been attracted to and long heard of, and now I have a really good reason to be part of it with my geographical location, so thanks to all. I'm going to talk for the time I have allotted about our surgical heritage, about the Morbidity and Mortality Conference. I have nothing to disclose in this talk, and just a brief additional word about Claude Organ. 1926 to 2005 was his life expectancy, so 13 years ago is when he died. And as Dan said, he was president of this organization in 1985. He was born in Texas, went to segregated schools, but his parents were both university professors, and he had two uncles that were physicians and clearly motivated him to become a doctor. He went to Xavier University in New Orleans, where he was, by his words and his family's report, faced with incredible difficulties from white professors as a black man trying to be a surgeon in New Orleans. He finished with his graduation and went to medical school and his residency in Creighton University, where he rose to the ranks, became chairman of that university, and then followed that, became chairman at East Bay. Interestingly, East Bay at the time in San Francisco was affiliated with UC Davis, and it's now affiliated with UC San Francisco, so there's some history with that, but Dr. Organ converted that into a remarkably strong training program. He was the editor of Archives of Surgery, I think you know that, for many years, founded the Society of Black Surgeons, and was the second black president of the American College of Surgeons. So with this quote here, it's my honor to present this lectureship and be part of his legacy of education. My talk is going to follow these principal points. I'm going to talk about our surgical legacy, particularly with Ernest Codman, a little bit about the Institute of Medicine report on deaths, and about why there are so many, and about the new development of various tools that both our administrators and we are using, administrative tools, to try to measure our outcomes. Then I'll get into the legacy of M&M, and with a particular focus on trauma. I think you're all well aware that when you take care of a lot of injuries or a lot of acute care surgery issues or just a lot of patients, you're going to have complications. We have this array of different people and different problems. Something is going to go wrong. And this isn't the right audience for this, but if you're a medical student and you can't deal with an error, and you find that making an error is too hard on you, you need to not go into surgery. It is no place for you, because errors are going to happen and they're going to be significant. Halstead, hard to start a surgical legacy talk without mentioning Halstead, and his contribution to this talk in particular was he advocated for having a medical record. He advocated for having a hospital charting system where the hospital kept the records of the program. Now, Ernest Codman, during his years when he became a surgeon, was certainly aware of Halstead and his writings. This turn of the century, late 1800s to 1900s, a fascinating number of kind of medical, historically accurate, common television shows are out now. The Nick is one of them about this time. Beaker Street in London, following the prostitution murders. What's the guy's name? Help me out. Yes. There's a series of whole shows that fascinate around this turn of the century, and all that medical developments were happening at that time. X-rays were being developed, anesthesia just coming into effect, and Codman died just at the end of when the antibiotic era was coming around. At the young age of 25, he was a staff surgeon at Massachusetts General Hospital, and his first career, he was renowned for being an ulcer surgeon and established a bone sarcoma registry. He used X-rays. He wrote about X-ray techniques. In fact, he wrote a book about how to use X-rays, which were just developed at the time. But his passion really was in hospital reform and in the hospital charting, perhaps taking his cue from Halstead, although that's not clear in any of the writings. But nonetheless, that was his passion. He wanted to chart everything that happened in the hospital. This is his hospital in Boston. The building is still standing. It's not a hospital anymore, of course. And this is an example of his anesthetic record that he kept on one of his patients. It looks so similar to current anesthetic records over 100 years old. It's a remarkable contribution. But this, you can't read it in the green, but it says the end result card. This is what he's known for. He kept this 5x8 card on every single patient he treated. He called it the end result program. He kept this card for 1 year, and he wrote notes on it, and he advocated that everybody should do this, and they should develop a method of reviewing these and present it to their peers. Essentially, the first M&M conference. So this is what he wrote. He said, this is a common sense notion. It's common sense. Every hospital should follow every patient it treats long enough to know whether their treatment has been successful, and if not, to ask why not. A classic presentation of what our legacy is in surgical M&M. It seems common sense, and it's very much embedded in our culture, but at the time, it was wildly rejected and not accepted. Because of his advocating this, he left Massachusetts General in 1911 and opened his own hospital, the picture I showed you of. He opened that hospital, he had 12 beds, and he did exactly what he said everyone in Massachusetts General should do, which is publish your results, and he had a 1 in 3 complication rate. I want you to file that number away, 1 in 3 complication rate, and he wrote about it. Everyone was afraid to do that because they didn't want to lose patients. And he was so irritated with his Harvard professors for rejecting him and for not following this that he published this cartoon. A cartoon looks like this. It's an ostrich with its head in the sand, who he calls the Back Bay surgeons of Massachusetts General Hospital. But they're laying, here it is here, but they're laying golden eggs. And the golden eggs are funding the entire university and the entire institution. And it says here, I wonder if clinical truth is incompatible with the medical practice at the time. I wonder if my professors could make a living other than saying bah humbug. And here's how the board of directors of Massachusetts General Hospital and Harvard University are trying to look the other way and ignore this fact. He was saying that you guys aren't telling the truth, you're not being honest about it, and the only thing you care about is making money, and shame on you. He got fired from Massachusetts General Hospital for saying that. He opened his new hospital. He continued to push this, but a short 7 years later, he got his vindication because he was one of the founding fathers of the American College of Surgeons, one of the founding fathers of the American College of Surgeons hospital standardization program, which forced Harvard and every hospital to do the same thing, and eventually turned into the Joint Commission. So in some ways he got his last laugh, but his end of his career was sort of marked by inconsequentialness. But he did make this change. It's kind of a lesson to be learned in there, I'm sure. When the college founded its accreditation program, it made this quote, that all hospitals are accountable to the public for their degree of success. How prophetic is this? And if the initiative is not taken by the medical profession, it will be taken by the lay public. U.S. News and World Report ranking of hospitals carries more weight than our assessment of whether we're doing a good job or not. How much money the hospital gets from following quality assurance programs carries more weight than what we think is important in patient outcome. And it's exactly because of what Codman said. So that legacy of Codman was one of individual responsibility and individual reporting. Right? And here's a modern tweet that's really, I don't know Mark Reed, but here's a modern tweet that essentially echoes the same thing. That individual responsibility, that taking responsibility for your outcomes, being serious about it, recognizing that you're going to have errors and trying to find ways to make it better, that was our legacy from the Codman era on. So that history, that sort of sets the stage for what the first 100 years essentially was of our legacy. But now let's fast forward that to these 2 papers that occurred in the New England Journal of Medicine in the 1990s. They were called The Nature of Adverse Events in Hospitalized Patients, again from a Boston hospital. And they looked at the practice of surgery, and they suggested that there are a number of complications, so many complications that in fact it's not the individual, but it's the healthcare system that's at fault. That was Lucian Leap was the author of this. Lucian Leap went on then to author the Institute of Medicine report that said it's not the individual physicians that it's fault, it's the system that's at fault. This is diametrically opposed to the Codman surgical heritage, history, and teaching of individual responsibility. So here's one main point of this talk, is that this tension currently exists between our legacy of individual responsibility and the idea that it's the system's fault, it's not any one of our fault, the system is just built wrong. Now, many do not like that approach. Many think that is wrong, and that's where the tension occurs in that. Who's Lucian Leap? Who was this new Codman? Professor of pediatric surgery. He authored those 2 articles. He went on to lead the Institute of Medicine report, and largely considered a father of modern patient safety movement. And here's the title from the book, To Err is Human. And it said when it came out in 1999 that there were 100,000 preventable deaths that occurred in hospitals in the United States each year. And like any good quality assurance program, the first response from people that are involved is, that can't possibly be true, the data is wrong. That is just your standard human response to a quality assurance program. So why are there so many deaths? And it couldn't really be this many deaths. Well, the first surgeons that looked at this, Mark Healy, Steve Shackford, when he was chairman of Vermont, said, I can't believe this. This is not true. We're going to prove it's not true. We're going to spend 1 year. We're going to go through every one of our records for all of our surgery departments. We're going to comb through it with a fine-tooth comb. We're going to look at our complications rate. We're going to extrapolate that to the rest of the country, and we're going to prove that the IOM report was wrong. However, they found a total complication rate of what? 32%. What? Codman, 100 years later. What? 32%. Same number, 100 years later. Are you kidding me? And in fact, of their 128 deaths, a third were avoidable. They went on to say, you know what? We were wrong. And the Institute of Medicine report is wrong because it underrepresents the number of preventable deaths there are by twice. The Institute of Medicine is wrong. There's twice as many as they say. And in fact, this beautiful article, actually in British Medical Journal, makes the argument that every death certificate should have on it as a possible cause of death medical error. And if it did, it would be the 3rd most common cause of death in the United States, following heart disease and cancer. And the data from it, for those of you who are interested, this is where that data is generated from, this number of half-dozen studies that continually go over this and continue to try to look at numbers and continually try to say, are there so many deaths? How can this be, right? How can this be that we don't recognize that there are this many preventable deaths that are occurring in the United States each year? Could we be looking, as Gage Oxner said, in the wrong place for where we're looking for these deaths? Well, maybe we're not identifying them. Here's a classic paper in JACS a couple years ago. And again, it took a Harvard hospital, and it said, let's retrospectively look at all of the deaths and all the complications we present at our M&M, and then let's look at what our NSQIP nurses are abstracting, and let's compare the two. Shouldn't all of our deaths at M&M be the same as what the NSQIP nurses are pulling out? Shouldn't that be the same? Why should that be any different? Well, it turns out they're wrong by a factor of 2. Mortality rates at traditional M&M were 1%. For the NSQIP nurses, they were 2%. 50% of the deaths were not being reported, and 4 times the number of complications were not being reported. So we simply, in our historical legacy, don't see them all. This is a little bit too hard to see, but what really says which ones are we missing? Wound complications, respiratory complications, urinary tract infections, central nervous, cardiac, others. It's true. That's not what we focus on in our M&M. We focus on mostly technical surgical issues, not these other things, but they're just there, and they're making a difference, and that's part of the legacy with it. And if you think we're bad, medicine is twice as worse. Beautiful article, I won't go through it. San Francisco took every one of the University of California, San Francisco hospitals, the VA, the Children's, every one of their hospitals, looked at their medicine M&M process, looked at their surgery M&M process, and compared them. And basically said, well, surgery's not so bad, but medicine's atrocious. They ignore all of their deaths, essentially, and almost never assign any reason for the deaths other than, oh, it just happened. And so, interesting, Andre Campbell, many of you know who's one of the authors on this. So what this has done, it has led to the development of administrative tools to try to track deaths. Our administrators, whether there are individual hospital administrators or whether there are federal government administrators or whether there are healthcare insurance provider administrators, have said, you're not doing a good job of tracking your complications. Just like Codman said we weren't doing. If you don't do it, we're going to do it for you. And that's where we are. We have all of these other groups tracking your complications by their administrative data tools, and they're not involving us in doing it. All right. And you know what all the administrative data tools are, the AHRQ, PSIs, or the NISQIP quality. If you use Vizient in your university hospital, or Vizient doing the same thing, they're tracking your complications. So we went from 100 years later, from never reporting anything and hiding it, to Codman saying you have to present it and it's your individual responsibility. And we've gone to the other side, which is, no, you know, we administrators, we don't believe anything you're doing, we're going to track it all for you. And so that's where we sit at this current time. Here's two examples of it. Ken Kaiser, the former CEO of the National Quality Forum, said, you know, I'm going to develop this list of things that should never, ever happen in the hospital. And I'm going to get a bunch of big insurance providers to agree to this. And these big insurance carriers, Aetna's, Blues, are going to say, if you have one of these, we're not going to pay you for it. That's what he did. He signed up all these big insurance companies and said that. Measured things that we think are clearly identifiable, clearly measurable, clearly serious, and we all agree should clearly never happen. Here's some examples. Surgery performed on the wrong body part. Let's say you come in for a hernia and leave with a circumcision. What do you think? That's a oops or a never event? It's a never event, don't you think? Surgery performed on the wrong patient. Oh, Edna Jones, not Martha Jones. Sorry. But the hip will last you a long time, Edna. Wrong surgical procedure performed. Retention of a foreign body. Oh my God. Our biggest complication. But my favorite, of course, is the last one. Honey, he looks a little funny. I don't think it's what we had in mind. So these are Ken Kaiser's never events. They're very similar to the Joint Commission's sentinel events. And the Joint Commission sentinel events are pretty important because if they happen, you have to report them. And if they're reported and they're real, they won't pay you, Medicare won't pay you for their subsequent health care. So if you have this complication, they're simply not going to pay you. Suicide in the hospital, homicide in a hospital, rape in a hospital, assault in a hospital. I kind of think, yeah, that shouldn't happen. Should not that. And maybe you think these things don't happen, but here's two reports. Sentinel reports on one side, never events on the other side. One's from the entire country from Joint Commission, the other one's from the state of Minnesota over 1 year, and essentially they happen a lot. These events happen arguably, agreeably, way too often. Is there an individual responsible for any one of these, or is it the system that's responsible for this? And therein lies one of the questions. So do we need both that internal M&M individual responsibility approach as well as the external identity ones? Probably. Do we still need M&M? I would argue probably. So why? Why do we have this problem? Well, there's thousands of hospitals, and most of the stuff happens pretty rarely, so most of the time we just kind of ignore it and doesn't think it really is that big of a deal. That's one reason. The other reason, of course, is that the technology and explosion of drugs and medicines and techniques makes it impossible, as we heard yesterday, for any of us to keep up with all this stuff. Impossible. So we become more specialized and more focused and more with blinders and more say, well, it's not my job. That's the consult. It wasn't me. I don't know anything about that. We're losing that whole sense of individual responsibility. We just have responsibility for the hand. We just have responsibility for the toe. We just have responsibility for the heart. We just have responsibility for the kidney, but only kidney diseases, not kidney surgery. It's just getting narrow and narrow and narrow. It's very complex. But really, let me propose that this is the problem. The problem is the culture of medicine and the paradox that it raises. We are supposed to be error-free. Mistakes are unacceptable. We are supposed to be infallible. And therefore, if we have a mistake, it's an error of our character. And if a mistake occurs, how can it occur without it being negligence? We are responsible for it. We're supposed to be infallible. So what is the natural tendency to this? Incredible shame. And the idea behind shame is to hide it. The strongest human emotion that we have that affects our behavior is shame. And our response to it is to try to cover it up and not admit it. That's the culture, the paradox of medicine. Our standard is perfection, yet errors are inevitable. So how can we learn from those mistakes And how can we get over that shame and embarrassment of that culture of perfection that we failed? So that's it. Charles Bosque writes about this in this book, Forgive and Remember. Charles Bosque was when he wrote this book, was a graduate student in psychology. And he spent 6 months going to surgical M&Ms at an unnamed hospital, probably was the University of Chicago. And he wrote about the culture of M&M that he sought from a non-physician standpoint, from a clinical psychologist. He looked at what does it mean, why are you doing it, what does it feel like? He states that Codman's often given credit for the analysis of fractures, outcomes, particularly in fractures, and that the history of M&M is not really unsure. It might be an anesthetic conference in Philadelphia, but Codman's largely given credit for it. But he states that the idea behind the M&M conference is to blame someone, have them confess their sin, forgive them for it by their peers, and give them some penance to remember it. For those of you who are Roman Catholic in the audience who know anything about Christianity, religion, this is the Catholic confession. This is Christianity's response to the Garden of Eden. The last perfect person that walked earth from a Christian standpoint was Jesus Christ 2,000 years ago. The way you forgive sins, he had to die for it. But part of that is we're given this ability to have a confession, to be forgiven for it, and to move on. If you're Jewish, of course, you just stay guilty all your life, and you don't sort of follow through this crowd. And if you're Buddhist, you see trying to go to a higher level. But it amounts to the same thing for humans, is how do we deal with fallibility? How do humans deal with failure and fallibility? And that's what the surgical M&M conference is. It's the equivalent of a Catholic confession. Accuse, blame, and confess. Bosque goes on to say that it's different for surgeons. When the patient of an internist dies, the natural questions his colleagues ask is, oh, what happened? But when the patient of a surgeon dies, your colleagues say, what did you do? How did you screw up? What did you do to cause that? Codman says, as an outside professional, this has some validity because surgeons have more to be accountable for based on their profession. Atul Gawande now writes about this in a remarkable series of books, both about the M&M conference and about complications, in Complications and Better, and about that feeling of how do you manage imperfection when you're expected to be perfect. That's what the point of this is. Now let's go back to that issue of the Institute of Medicine report that's saying, now these errors are not the result of recklessness or the actions of any particular bad apples. It's the system who allows these errors to carry through. Now, that is not to say there aren't some really idiotic moves that you can make out there. These are called normative errors. If you're behaving outside the norm when you're practicing medicine, those are normative errors of your trainees or your colleagues. We have to recognize those. Doing things that just are simply stupid and are going to cause problems in patient care are just unacceptable. That's sort of not what the Institute of Medicine report is talking about. It's talking about the vast majority of errors that are the result of a system fault. Now, you could say that perhaps this machine ought to have built on it some automatic stop. If you stick your leg into the machine, it's not going to run, right? That would be a system solution for this. Or you could say this is just Darwinian and thinning the herd, and that idiot ought to be sucked into that machine and spit out the back. Right? That's sort of the point of this, is which one of these is the right way to go with this. Jim Reason writes about how you prevent these errors from happening. And he makes the argument that, no matter what you do, you might not be able to do it. If you build a lot of firewalls to prevent an error from coming through, each firewall you build still has a flaw. There's no perfect firewall. And you can build as many as you want. He's got 4 of them built here with the model that is like Swiss cheese, that each firewall has a hole. And occasionally all those holes line up and the error still gets through. So he talks about the latency of errors, and the latent errors are defects in design and organization that lead to failures and errors. And he says there are a huge number of latent errors in the healthcare system. A classic example of what's a latent error is those doors on the side. All right. If you walked up to those doors on the side, would you push on that door on the side, or would you pull on that rod? What would you do? If you walked over that door, how would you get out? Anyone in here, would anyone in here pull on those? Because if you are, you're going to get on my next slide, you know, of those last guys. No, you push on that door. That's a design that prevents you from making an error. But if there was a handle on there and not that bar, you might pull, you might push. Right? And it may not work one way. It may only work the other way. That's a design error. And Reason says that's what's the problem with healthcare, is we don't have enough of these latent error fixes, these design error fixes in medicine to prevent all these things from happening. So that gets into the next book of the Institute of Medicine, which is Crossing the Quality Chasm, and says, what do we do? How do we get from all these errors? How do we rectify this issue of individual responsibility with societal changes? And how do we make this issue that we're as error-free as possible? This gets into a really fundamental issue of where we get frustrated in our hospital and working with people on the same thing. We all want the best outcome for our patients. You might argue that hospital administrators want so that they can make more money and take home bigger bonuses, but they still want good outcomes for patients. You can argue that you want it because you actually care about the patients and want them to do better, but you also know it's a lot less work if there's error-free complications. So we sort of all want the same thing, maybe for a little bit different reasons. The problem is safety, which is what hospitals push, what the administrative data pushes, is the avoidance of a negative outcome. That's what safety is. Safety says, let's avoid a negative outcome. But quality is the achievement of a positive outcome. We as surgeons want quality of care. Administrative databases are pushing safety practices. There's a tension between those two because safety is demoralizing, quality is enabling and team building. And somehow we have to recognize those two differences and come across with them. Well, let me finish up here a little bit with an example of what's happened in trauma with this. So if you go back, trauma quality assessment, back to Codman, fracture assessment, led to the Joint Commissions. But really what changed trauma practice were these preventable death studies that were popular in the 1960s and 70s. And preventable death studies, I think most of you know what they are. They're basically saying that someone external from you came in, looked at your institution, looked at all the deaths in your institution, and made a decision about whether that death could have been avoided. And the classic reason for a death that was avoidable is someone bled to death from a ruptured spleen that you didn't recognize on time. Or someone had a perforated intestine, you put them in a corner, they got septic. By the time you recognized they had this delayed perforation of intestine, they got septic, it was unable to recover them, and they ended up dying of their sepsis. Those are the classic preventable death studies. I bet most of you didn't know this, but the first preventable death study was reported by Robert Zollinger of the ZE system, the chairman of Ohio State. I didn't know the guy knew anything about trauma, right? ZE. But his presidential address to the Society of University Surgeons was the first preventable death study paper. And he said a preventable death rate across the country was high. Trunke reviewed all the preventable death studies in this great article in 1989 in the Journal of JAMA. But basically, there have been 50 of these studies, and they all look about like this. Let's just an example. Orange County in 1974, Southern California. The surgeons in the community said, we have a bad problem with preventable deaths and trauma. We want to develop a trauma system. The other half of the town said, no, we don't. We like it the way it is. Don't mess with us. We're an ostrich. We have our head in the sand. We're laying golden eggs. Standard Codman sort of. We don't want a trauma system. We're doing just fine. But if you want to have an exercise panel come in and do a preventable death study, let's do that. So they did. 1974, a preventable death panel came in. They said, you had 30 deaths in trauma in a year in your city, in your county. 11 of them were preventable. You had a what? 37% preventable death rate. Oh my God, Codman, 100 years later. 37% preventable death rate. And most of them were from bleeding. How did they respond to this? Just the way Harvard did. No, can't be true. We don't believe you. You're fired. Leave. We're going to hire our own preventable death study group. So the people who were opposed to it hired their own group of physicians to come in and do a preventable death study. They did 4 years later. They found 21 deaths that occurred in the trauma system. This time they decided that 15 of them were preventable. So their preventable rate went up to 71%. That changed. That's what made the trauma system occur in Orange County. And after the trauma system was put in place, the trauma center hospitals had a preventable death rate of 9%, and the other hospitals that weren't in the trauma system, preventable death rate of 67%. This type of preventable death study occurred across the country. San Diego, Los Angeles, Tampa, 50 of these studies across the country, all showing the same thing. And what do they do? That led to the development of trauma systems across the country. I don't know what, okay. So that led to trauma system development across the country. It changed healthcare. It's responsible for changing the system of delivery of care. right? This wasn't focused on individuals. This was focused on how we deliver healthcare as a system. So a change at delivery of healthcare by changing the system of healthcare. That's one of the arguments of the Institute of Medicine report. Here's a classic from it, though, for where this tension occurs. What used to be called preventable deaths, individual responsibility, this was a possibly preventable death, is now called an anticipated mortality, we expected it, but with opportunity for improvement. But my favorite is this one. This used to be called a preventable death. You screwed up, you guys killed this person, and they should never have died. That's what site reviewers would come in and say. You screwed up. Anna Ledgerwood would show up in your hospital. She'd look at you and say, you had 10 deaths, those were clean kills. You killed every single one of them. What's the matter with you? That's what she would say. Don't say that now. You say this, oh, that was an unanticipated mortality, and I think you have opportunity for improvement. This drives people nuts. It's like giving a medal to everyone who participates in a game. This just drives a certain culture completely crazy. But it's that tension between system changes and individual responsibility. So modern safety, if you want to call it that, is looked at adverse events, at error prevention, and enlisting stakeholders, and there are ongoing challenges to it. Lucian Leap, who we talked about, and then Don Berwick, who's the head of CMS, wonderful article about it in 2005. So the contemporary approaches are to improving recognition, finding a way to recognize them also not hiding from us, having a standard classification systems, we can talk about them, and then looking at the system factors of latent errors that occur and how we can fix them. I'm going to give you one example of this tension. Real case, real example. 69-year-old male, motor vehicle crash, traumatic brain injury, and multiple extremity fractures, sits around in the ICU for a couple of weeks, isn't able to get off the ventilator, and eventually has a tracheostomy done on day 14. Now, this is a stocky, would be fair, would be kind individual, short, fat neck. Trach was done as an add-on, so it was late in the day. By the time it was done, it was 8 o'clock at night or so, and everybody who was responsible for the patient went home, leaving the patient in the ICU by a hospitalist covering the service. About 6 hours later, we're now at 2 a.m., a leak was noted from the trach. And the bedside nurse and RT were constantly at the bedside manipulating this tracheostomy and trying to fix it. So you're the house staff, us hospitalists, had nothing to do with this case, maybe never have seen a trach before in your life. We're called to assess. So what do? See the patient, try to troubleshoot it. There's some individual responsibility there. So you get out of bed, that's normative behavior. If you just rolled over and said, yeah, it's fine, don't bother me, that would be a non-normative behavior, and you would get fired for that. But normative would be to show up and troubleshoot. So then what do, though? Do you call anesthesia, ask them to innovate, take the trach out? No, you're going to piss off all the surgeons. They spent forever trying to get this patient on the OR schedule, and you just destroyed it and ripped it out? Maybe. Make a note, discuss it on rounds, make sure it's the first thing the team knows about when they come in, maybe. Call the attending at home. Dr. Jones, you don't know me. I just having trouble with this trach in your patient. It's 2 o'clock in the morning. Can you come in and fix it for me? No, you're not going to do that. They're not going to pick up the phone. So what happened? Well, the physician saw the patient, made a note to discuss it on rounds, and just before morning rounds, the patient coughed and the trach dislodged. Of course, they couldn't tell because of a short, fat neck and it was in the subcutaneous tissue. So the patient desaturated and they couldn't figure out what was wrong. And then they figured out what was wrong, and then they tried to reinsert this trach without stay sutures into a fresh neck and poking away at this trach in this short, fat neck, and they couldn't get it in. And they tried to intubate the patient, but they failed in doing it, and the patient died of respiratory arrest in the ICU at a level 1 trauma center. That, in Anna Ledgerwood, I'm just picking on Anna for no reasons, but that, well, for a reason, she's old. She's even older than I am. So that old school would have said, that is a clean kill. We're going to find out who was responsible. We're going to hang them up. We're going to make them come to confession. They're going to confess their sins. We're going to give them some penance, like, I want you to look up tracheostomy complications presented at Next M&M. That's the essential of, 3 Hail Marys, 5 Our Fathers, and a rosary, and show up. And that's what you're going to have to do, and that's penance. But then we're going to forgive you for it. We're going to say, well, at least you showed up, at least you evaluated, maybe you didn't know, so we're going to go on. But we're going to remember it. So there's lessons to be learned from this. There's no question about that. And the M&M approach would have been to identify them, to blame them, to forgive them. Really, that's our culture. We would forgive them and hope that they remember it forever and know that everyone in that room knows about it. But also know that 3 months later, there's not going to be a single person around who was part of that case. There's not going to be a person around at all who had anything to do with this who's going to remember anything about this. So what do? What's the other approach? Do you write a system-wide policy on the management of fresh tracheostomies? Is that what you do? Do you write a hospital-wide policy on it? Do you track those problems? Do you revise it? Do you see what happens? How long does that take? How many people hours does that take to make that happen? So does it make a difference? Is that actually going to change this outcome? What do you do? Which of these approaches is the right one to do for improving surgical quality? That's the rub we're in. Oh, I don't, this one's too long. Let me skip through that one as well. Same case, same sort of issue. Bad. We had 2,594 deaths over a 10-year period when I was in Seattle at Harborview. Russ Gruen was our fellow at the time. He's gone on to lead much of Southeast Asia, Australia's quality assurance programs, great fellow. And we looked at every single one of those deaths, and I'll just get to the meat of the matter. We looked at the errors and the cause of the errors and where they were occurring. And we divided the nomenclature of this. Did the error you made in those 2,594 deaths, was that because you weren't skilled enough to do the operation? Too junior, didn't know the technique, made it too critical of an error, i.e. stuck a femoral catheter above the inguinal ligament, went through the artery, bled into the retroperitoneum and died from that. That's a technical error that you just didn't know, weren't good enough to do the skills. Or were you missing some knowledge? Were you just ignorant? Were you too junior? Did you just not know that if you change serum sodium by more than 10 over a 4-hour period, you're going to get brain edema and then you're going to stroke from it? Did you just not know that? Were you too junior to know that? Right? Or do we have rules in place and you just didn't follow the rules? The rules are all there. We wrote all the rules. We wrote all these policies. They're all in place. And you weren't following them. Yes, the number one cause. Protocols are all written, they're all in place, and you're not following them. That's what we found. So we wrote some rules, we did some things different. In fact, we had great result with some rule writing. We changed the way you manage thoracic hemorrhage. We changed the way we transfer patients to the hospital. We changed the way we use feeding tubes, and the changed the way we manage foreign bodies at the end of a case. And as a result of that, those problems went away. They disappeared. So we were able to impact some system changes that clearly influenced those complications. Oops, sorry. But on the other hand, we had a whole lot longer list of things that we tried to do that had no effect on outcome. None at all. All that list on the left we made changes to. We wrote policy changes. We did something different that was a significant policy effective change issue, and it had no effect on the occurrence of that complication. Sometimes it works, sometimes it didn't. So as I end up here, I'll say that preventable deaths occur even in a mature trauma system. Kind of standard thinking right now is you have about a 2% preventable death rate in your trauma system. And if you're less than that or at that, you're probably doing an okay job. If you're higher than that, you need to relook at yourself a little bit more carefully. So there's still individual responsibility there. And that there are patterns of errors that occur, and you should be able to recognize those patterns, and you should be able to respond to them. And if you look at your own place, you can see what your patterns of errors are. For ours, it was we had the rules, people just weren't following them. We tried to make some changes for that. Error reduction certainly begins with recognizing that you have these errors, recognizing where your patterns of errors are, and then trying to respond to it. I will end with saying that I do think our major challenge right now is in the frequent handoffs that we have. The constant changing of doctors and people and the handing off and the loss of information, that puts on a whole other layer of complication that we have in trying to deal with this. So how do we improve? What lessons do we take away from this when 99% of the time we're fine, but 1% we fail, and that failure is very devastating to us? Can we be perfect? Is that a reasonable expectation? Can planes never crash? I know that most of you flew here. You expect your plane not to crash on the way home. Pretty much, I would bet. Anyone think that their plane's going to crash on the way home? No, probably not. But they do. This is from San Francisco, just a couple of years ago. Planes do crash every once in a while. We expect our cars to be perfectly safe. Those in the audience will recognize this as a Pinto. The Pinto had the problem whereas the gas tank was too low in the back and it wasn't shielded enough, and if you rear-ended a Pinto at all, even like a fender bender, the gas tank would rupture, spill gas, and explode. You got to love a Californian who keeps his Pinto and has that vanity license plate that says kaboom and drives around. That's pretty cool. So can planes never crash, cars never fail? Even the worse. Can nuclear reactors never fail or oil rigs never fail? No, they fail, they fail, they fail, and they're supposed to be perfect. So that's our expectation in surgery, and that's a dilemma we're placing right now, and how to solve it remains enigmatic, but we're at that tension point between those issues, and I still think that surgical M&M has a key role in this. Thanks for your attention, and thanks for the honor of presenting.